Welcome everyone to our panel this morning on opportunities and issues for the care workforce. I'm really excited about this panel. Been working with the panelists to organize for quite a while now. So we're going to start with Robert Espinoza from PHI.
Great, thank you. Good morning.
Wait, actually, I'm sorry, but I think I'm supposed to say something about the rules. Hold on one second.
Yes.
Yes, give me that one slide. There we go. Okay, so sorry, before we start, I'm supposed to go over the rules. So first of all, you should feel free, if you don't know already, to tweet about this session at #CareInfrastructure2022. The webinar is being recorded, so everybody please be aware of that. It will be made available after the event. You need to put your questions in the Q&A. If you put them in the chat, we won't get to them. So please put them in the Q&A, but please use the chat to talk to each other and introduce yourselves if you're online. And finally, there are closed captions available for attendees who are on Zoom. To turn on closed captions, you should click on the CC or transcript button at the bottom of your screen. Okay, thank you. Okay, Robert, now, wait 1 second while Barbara get your slides up, and then the floor is yours.
Great. Thank you so much. Good morning, everyone. It's good to see all of you, both in person and online, especially on a Saturday morning. It's really beautiful out there in DC. So thank you for joining us this morning. And thank you for inviting me and PHI to this conversation. It's so critical. And I'm excited to be able to share our insights and our data on this critical issue. Can we advance next slide? Just for those of you who aren't familiar with PHI, we are a national organization that's focused on strengthening the direct care workforce. And we do that work in 3 ways. We study the workforce and produce data, research reports, policy analyses on critical issues that are facing these workers. We also advocate for reforms at the federal and state level. We have an initiative right now in 6 states. And we also design workforce interventions. We partner with employers to design training programs, advancement opportunities, recruitment and retention strategies, and so much more. And so what I'm sharing comes from what we think is a 360-degree perspective on this workforce and the long-term care field. Next slide, please. Just in terms of thank you. Just some foundational points. So by direct care workers, we define them as workers who are supporting older adults and people with disabilities in a variety of long-term care settings. So they work in private homes, they work in residential care communities like assisted living, and they work in nursing homes. We estimate that there are about 4.6 million direct care workers throughout the country. And they often go by different titles, depending on the state, depending on the occupation, and sometimes depending on the employer. But by definition, they are supporting older adults and people with disabilities. Next slide, please. Because there are so many new jobs being created through growing demand, and because turnover rates are so high within direct care, we estimate that between 2019 and 2029, there will be about 7.4 million job openings in direct care. And this is a formidable challenge when we consider that so often these jobs are poor in quality, as evidenced by inadequate compensation, by limited training and advancement opportunities, by a general lack of respect and recognition that these workers deserve. But it is important as we think about the future of this sector, the kinds of challenges that we have in filling those jobs. Next slide, please. I want to share just a few points here. This is kind of to frame the conversation about the federal opportunity here. I think many of us who've been working at the federal level for years have been really kind of encouraged, I would say, by the variety of proposals and measures that have been put forth this year and last year in regard to the direct care workforce, especially the Build Back Better Act, although I know that that's currently in flux. Somebody referred to it yesterday as the Primal Scream Act, which is a kind of a funny way to think about just the politics of that act this year. But what we are seeing around the country is that in particular, the American Rescue Plan Act, which is a short-term one-time spending opportunity, that many states for the first time are proposing strong measures that would strengthen these jobs in ways that they really never have before. And we're hoping that that really sets the stage for what states can do in the long term and hopefully what the federal government can do moving forward. We're seeing proposals around an earned pathway to citizenship that would support a sector where 1 in 4 workers is an immigrant, acts that would boost funding for recruitment, retention, and advancement initiatives in this workforce, and a variety of other measures that could go pretty far in changing the landscape. Next slide, please. Early last year, recognizing the opportunities of a new president, we issued a federal policy report with nearly 50 policy recommendations across 8 issue areas. These are recommendations not just at the legislative level, but also for agencies and departments that can be issued in a variety of ways. And I'm going to be drawing my remarks from that report. And I would encourage other people who are interested more in the specifics to look more closely at it. Next slide, please. The 8 areas start with financing. It's important that we think about the financing of these jobs and the financing of long-term services and supports in general. I'm excited that Ben is on the call today because to think about job improvements in direct care, we need to think about a system that is financially stronger, that would both improve access to services and supports for older adults and people with disabilities, but would also design those measures in such a way that would also improve jobs. And I know that Washington State has really an ideal approach there with their state-based social insurance programs. Of course, we do live in a country where attacks on Medicaid and the public safety net are pretty common, unfortunately. And so we do need to think about protecting and reforming Medicaid to make sure that employers have the kind of supports that they need to improve these jobs, and also that consumers, many of whom are workers themselves, can also access both healthcare and long-term care. Next slide, please. Another area is compensation. When you ask workers in many studies, what are the 2 reasons that they're being driven out of these roles, they often cite inadequate compensation and poor supervision as the top 2 reasons. And compensation makes sense. This is a median wage where it's about $13 an hour. It's budged only by less than $1 over the last 10 years, adjusted for inflation. When you count the fact that many workers are often relegated to part-time work, either by their employers or by the economy, about 45% of direct care workers live in or near poverty. And if anyone who has lived that reality or studied that reality, that's crushing, and it's often entrenched and generational. And so increasing compensation to at least a living wage that accounts for local cost of living is a critical piece. And yet it's probably more than a living wage that direct care workers need. I shouldn't say it's probably, direct care workers do need more than a living wage, just given the level of skill and knowledge that's needed to fulfill these roles. Next slide. But also because it's simply not a wage that's competitive with other comparable occupations in terms of entry-level requirements. This is a US map of a study we did a few years ago, where we looked at the median wage for direct care and compared it to occupations with similar entry-level requirements. And what we found is that in no states were direct care wages equal to or higher than occupations with similar entry-level requirements, like janitors, like retail salespeople, and customer service reps. And when you looked at occupations with lower entry-level requirements, there were 26 states that actually had higher wages than direct care workers. So what we need is not just a living wage and a wage that's commensurate with the level of skill that's needed for this work, but we need a competitive wage. Otherwise, employers simply cannot compete in the market. Next slide, please. Another area is, of course, training. Here I would reference a few points. One is the training requirements, which are especially thin for personal care aides, which don't do the clinical tasks that home health aides and nursing assistants do. In no state do training requirements go more than 40 hours for people in personal care. And it's an area that is growing. In fact, it's the largest part of the home care workforce. It's the kind of support that many of us need as we age and as we manage our own disabilities. Also, we have found that even when states have strong training requirements, the training infrastructure is not as updated as it should be. It's often under-resourced. It often doesn't embody the modalities that adult learners need or people with limited English proficiency might need, which are the kind of demographics that are often in this workforce. And virtual methods, which are getting a lot of attention, are rarely evaluated for the impact that they might have in actually equipping workers with the knowledge and skills. And so there needs to be a complete overhaul of that infrastructure. Next slide, please. Of course, there are a range of interventions that are also needed for this workforce. Everything from, I mentioned training, but also advancement opportunities, both within direct care and also beyond direct care for workers who aspire to that. We also need recruitment and retention initiatives that can help employers design new ways to build the pipeline of workers going into this sector and also advance into it. Next slide, if it's possible. If not, I'll go by memory.
Sorry, I'm just having a little captioning issue.
Oh, no problem.
Oh,
This is an example in Arizona. Mercy Care is a managed care plan that launched a $1 million innovation fund for their providers to test and evaluate recruitment and retention interventions for direct care. And if we thought of this as a policy initiative, both at the state and federal level, where we could put more money into recruitment and retention interventions, among others, and compel evaluation, we could weed out programs that work from those that don't. Next slide, please.
absolutely. Sorry.
No worries. Another dimension, matching service registries are online portals where workers can find consumers and consumers can find workers based on preferences, needs, and availability, yet most states do not have matching service registries. And so, of course, this is a policy need that could be engendered both by more funding at the federal and state level. Also, we need better data collection. Too often states don't collect enough data on minimum points like turnover and staffing and vacancy rates, much less on disparities within the direct care workforce. Next slide, please. We have found, for example, that often women of color and immigrants and people of color more broadly have great disparities compared to their white and male counterparts within direct care. And yet we need more data to better understand that. We work with Texas to better understand their workforce requirements around data collection, which requires that kind of data collection, not so much the disparity data, but at least the minimum data set. And this is a need at the state and federal level as well. We would argue for, of course, a range of measures that would target the kind of specific inequities that women, people of color, immigrants, LGBTQ people aged 55 and older, and so many other populations are facing. Next slide, please. We did a study 2 months ago, last month, where we looked at disparities within direct care, and we found that women of color in direct care are likelier to live in or near poverty than men and white women. Next slide, please. We also found that Hispanic and Latino workers have the lowest annual earnings of any racial or ethnic group. Next slide, please. And that Black African-American direct care workers have the lowest family income among all direct care workers. And that is typically a measure that looks at kind of the totality of the income earned in the household, but it's also related to a legacy of systemic racism, right? And the ways in which that has depleted the resources of people of color in so many ways. We would argue for centering direct care workers as experts in public policy. Right now, we're working in Maine with their state offices to create a better policy-making body process where workers themselves are advising policy craft. And so we would argue for that as a major need. And the final point I make, because I know I'm limited on time, next slide, please, is related to the public narrative. We do not have enough awareness as a country about the challenges I've described, which impacts the kind of industry solutions we need and the government reforms we need. It can also be looked at in terms of recruitment measures. How do we build marketing campaigns to better recruit workers into this sector, specifically new populations that might be underrepresented in this sector? Next slide. All of this next slide, I'll just pass this one for time purposes. All of this information and much more is available on our website at phinational.org. Thank you again, and I look forward to hearing my fellow panelists.
Great. Thanks so much, Ben. Robert, that is last. Okay, next we have Eileen Boris from University of Santa Barbara.
University of California, Santa Barbara. And what's wonderful about going after Ben is that some of the areas that he's highlighted, I'm going to highlight in a different way. The questions of financing, policy, federal-state relations, and workers at the center of recreating our understanding of care and what can be done. So I'm essentially a historian by training, although involved in policy. And the takeaway from this presentation is really two. That what is needed what is needed is not because our systems, it's because of our systems of care developed out of previous policymaking and we have to understand that what is need not be the only thing, that change is possible, and the systems we have today are part of struggles that produced a limited, racialized welfare state that maintain the fictive lines between agendaed public and private. And these can be changed despite the afterlife of slavery, gaps in citizenship rights, and the devaluing of care as work. And that my second point is that central to change are the struggles of care workers themselves, that they possess knowledge and experience and are leading the way and offering strategies for the present to build a caring future. Next slide. Okay, so just to go very quickly through some of this history, my argument is that the state organized home care, that during the New Deal, there was a new occupation, neither nurse nor maid, but the visiting housekeeper as home attendant. We live with the legacy of the New Deal. That is, that many of these workers were excluded from labor laws because they were classified with domestic workers who were also excluded from labor laws, and also because they were attached to public assistance, the poor caring for the poor, that this was considered low-wage work for women of color who were on public assistance, but they were also caring for people that were on public assistance. And nurses themselves were struggling in this moment to define their own profession and thus wanted to differentiate themselves from the home attendant and care worker. Okay, next slide. I want to back up just for a minute to say the origins of home care was in what I call the substitute mother movement, a kind of reverse foster care provided by child welfare and religious-based social services beginning in the early 20th century, then taken up increasingly with the crisis of the Depression and into the early post-war period by local public health and welfare departments. And many of these were connected to the Children's Bureau. And yet, when we think of home care, we think of it separate from foster care and other child care services. Next. And this image just visualizes for you the shifting clients from homemaker services, the caring of small children, notice Black women, and depending where in the country, having a white attendant. For elders. This was from Wisconsin, the other image. And this image is from the very early 1960s. Next image. Okay. In the Great Society in the LBJ days, we see this persistence of what I call a double rehabilitation. Independence for seniors, that is, to be able to stay at home or the community, and people with disabilities, would be happen through the ending of dependence on the state for poor single mothers who would be trained through workfare. Now, we know this was not adequate for anyone. And often the emphasis was on the domestic work done rather than the direct care. Medicaid, as we just heard, became the basis for long-term care, but Medicaid in many states remained underfunded and stigmatized. Next image. I want to switch to California with some discussion of New York, which were the two of the major areas. Though Oregon was quite innovative as well. And we have, in California, we have an example of the way federal policies were interpreted on a state level with the emergence of in-home supportive services, beginning with an attendant care program under Social Security, that actually the state was laggard in doing. And here we see social movements incredibly important, the independent living movement, for example. The state had to possibly modify in its acceptance of supplementary security income and created IHSS out of that, and which allowed for the consumer, so-called consumer, to be really have charge, or the consumer's family and kin, through what was called an independent provider model. But as one of the images here, you see, there was always this struggle for financing. And it became one of these tug of wars between governors, state legislators, the disability rights movement, and eventually a senior movement, and eventually unions. Next image. So here's just some notion of some of the struggle over the funding since covered by Medicaid rather than Medicare. The program became means tested and thus stigmatized. Many middle income, elderly, and people with disability had absolutely no help in obtaining quality home care. And because people increasingly began to prefer staying at home and nursing home crises in the early 1970s, this was a problem and really led to what we might call a shadow economy, jobs for new immigrants and others, because people could not afford. So we're talking about the demand side as well as the supply side. And there were many, many new programs and such, but it was very difficult and has been difficult to sustain the level of funding for an adequate caseload growth, as well as need to improve wages and benefits for the workers. California created a public authority model, and unions have sought to improve the quality of care through training and other and respite providers and local registries, but it's been a funding problem. Next. Okay, so by making what was private in the family and in the nonprofit sector public, that set the stage for unionization. And we really see a confluence of public sector and service sector unionism. It was hard to find who the employer was in the kind of matrix of policies and funding in the state level. SEIU took a great lead in this. And we have a confluence then of service sector unions, healthcare unions, and the civil rights of domestic workers coming together in some of the major union drives in New York and California in the period from the late 1980s into the mid 2000s. Okay, next image. We also have what we call lobbying the state. That this image is from Chicago in 1992, when we see workers and their consumers lobbying together for increased funding and thus higher minimum wages as well. But many states had a split between having old age and Department of Rehabilitative Services, as Illinois did, in dividing where the funding would come and having different rules for different kinds of clients. Okay, next image. We have this, how many more minutes do I have? About 5?
Yes.
Okay. Ethnic worker associations and centers with a new immigrant workforce in private homes in that shadow economy. And I'll just continue on here to the next image because I want to just introduce a couple of other concepts. These domestic workers who were covering some direct care workers also began to see the law, as did the unions, as a mobilizing device. And we had in the last 20 years, domestic worker Bill of Rights in New York first in 2010, in California, and in the international level, and a play between the local and the international with the ILO, next slide, Convention 189, which has set, if we can have the next image. Yeah. Which has set a standard for the labor standards for household workers of all sorts. We'll have the next one, next image. These standards, though, have been aspirational. And here I just list some in the Domestic Worker Bill of Rights. Occupational health and safety is limited. And I'm just going to focus on that for a minute compared to what the ILO. So I want to move on, and people will be able to look at this when you get the video of the image. I want to emphasize about the current struggles right now, in which strategic alliances are really building in, at least California, enforcement for empowerment. That the National Domestic Workers Alliance created hand in hand as an employer organization to work with. And we see the influence of the ILO, which has this employer, worker, government partnership. But NDWA is really use the hand in hand to educate employers and create voluntary standards that are based on worker understandings in their experience. And the California Domestic Worker Coalition has been struggling from at least 2005 to get its Domestic Worker Bill of Rights and other laws. And it finally in 2016 got one, but was really limited to overtime. And IHSS, the home care paid through the state, was exempted from these laws. And that wage orders for domestic workers would cover some personal attendance, but other wage orders covered direct care workers in residential facilities. So in next image, in the last few years, I've been part of a campaign for health and safety for all, that the wildfires and the pandemic have led to the coalition of domestic workers and their allies to really try to end the exclusion of all household workers from Cal OSHA, which is replicated from the federal OSHA. And this has been an over 2-year campaign with lobbying, innovative Zoom campaigning, and social media, and various public demonstrations. Next slide. Initially, Governor Newsom vetoed our first bill because he used those old canards that that home isn't a workplace, and that there would be no way to implement this, that it would be too costly. And the reactions of the workers was public die-ins and continuing the campaign. So next image. However, the governor told us that he would veto the bill again. So through a democratic process of all these ethnic associations and regional groups, Filipino Workers Association, Mujeres Unidas Activista, many of these groups, they came together and actually decided, okay, we'll accept a law that will bring together stakeholders, including workers and worker representatives, to determine what voluntary guidelines for health and safety in the home would be. Meanwhile, other workers in San Francisco gained a paid sick leave. So I think I'm going to have my last slide. Yeah. Ooh, well, I guess I'm not having my last slide. So I just want to end then there. And just to say that yesterday there was a convening with the Division of Labor Standards Enforcement to bring in the voices of domestic workers themselves to essentially do what Robert was ending with, to bring the knowledge of those who do the work into the construction, not only of the policy, but their implementation. Thank you.
Great. Thank you very much, Eileen, for that excellent context setting. And Sarah Nolan from SEIU will now pick up on the struggle part.
That was a great history. So thank you. So I'm Sarah Nolan. I lead health policy at the Service Employees International Union, which, as some of you may know, represents home care workers, among other types of healthcare and public employee workers. And I do a lot of work on Medicaid. And so this is I'm going to echo, I think, a lot of what Robert and Ellen said, but again, from a sort of different perspective, and from a pretty Medicaid perspective. In line with the description of the panel, I'm going to talk specifically about the possibilities for leveraging public policy, especially spending increases, to improve labor standards. And I'm actually also going to start with some history, but then focus on the design of the current Hcbs infrastructure legislation that's part of Build Back Better. And so this is less about why we should do it and more about how we do it. So the undergirding rationale is really a belief that public dollars shouldn't support crappy jobs. And that's especially true with home care, where Medicaid is the main funder. And this is not a new concept. There's a long history, starting with Davis-Bacon in 1931, of tying or of requiring federal contractors to pay prevailing wage. And we know these provisions actually helped raise wages and reduce income inequality among workers employed by those contractors. But it's tricky to do this in a social insurance context, right? Because Medicare and Medicaid aren't procurement programs, and that's a fundamental difference. They're not buying services from people, they're paying for healthcare services, which of course are provided by people. So the rules focus on the beneficiary, not the worker. So how do you embed workforce standards in those programs? I would say Medicaid home care delivery models also present some challenges, as does the fact that Medicaid is a state and federal program. So first slide. So just a little bit of history. I just want to point out that we have already seen a large influx of dollars in home care. So this slide shows Medicaid home and community-based services spending as a % of all long-term care spending, first in 1985, and then in 2019. You can see the huge growth. In dollar terms, we've gone from spending about $1 billion a year to spending $116 billion in 2020. And just a definition, home and community-based services are services that allow elders and people with disabilities to stay at home in the community. The biggest part of it is home care. It includes other types of services as well, dayhab and things like that. Next slide. So we at SAIU like to say that without a home care worker, there is no access to services. In fact, home care workers make up the bulk of the Hcbs workforce. We think, and as Robert pointed out, the data are sometimes lacking, but out of the 4.6, I think you said, million direct care workers, upwards of 2 million are Medicaid funded home care workers. I would just note there are also workers in the gray market. It's a very large gray market, and a lot of this work is done without pay at all. Really important, kind of wonky. There's two main service models. One is, and Eileen alluded to this, I think, there's the agency model where a home care agency employs a worker and pays the worker a wage. But in the consumer directed model, like in California and in many other states, there's what we call the IP model. Its consumer directed model is the consumer hires and directs the worker, called an IP usually. And in this model, the consumer is considered the employer, sometimes a co-employer with the state. But what that means is you have kind of a million different or several hundreds of thousands of individual employers employing home care workers. The model is extremely important to the disability community because of the maximum autonomy, and it sort of comes out of the history that Eileen talked about. So we know the workforce has huge challenges that I think this whole conference has spoken to. Just noting in the past, they were excluded from labor protections, particularly the IP workforce. These are hard jobs and the pay is low. But a major problem is the fact that IPs don't have a common employer. And the general disaggregated nature of the system creates huge barriers to organizing workers and to collective bargaining. And we think collective bargaining is one of the key ways to raise standards for workers. It also, frankly, creates a barrier to providing benefits to workers, right? If you've got a million different employers, each individual consumer, how do you provide health insurance in our system? So next slide. So our immediate policy solution, or our historical policy solution, was when workers began organizing in the 80s and 90s, was to create what we call a public authority model, which Eileen mentioned. And that's a state where a state or a county acts as an employer for the purpose of collective bargaining while leaving it still to the consumer to manage services. The entity can recruit workers, it can provide other supports to workers and consumers. So for example, the Massachusetts PCA Council is charged with recruiting, training, and stabilizing the workforce. And some authorities actually do operate registries that link consumers and workers. And there are about 600,000 IPs are organized under this model in 7 states, mainly by SEIU, also by AFSCME. Next slide. So these workers have actually had a lot of success. So in the 7 states where we have organized workers, wages are at 15 or frankly, somewhat well beyond that, in contrast to the average wage, which I think is $12.90 about. Workers have access to training and benefits like healthcare, and pensions in Washington, I think. More amorphous but important benefit is that workers who have come together have a voice, they have a chance to talk to other workers, and that's pretty key to improving the quality of jobs. And it's allowed workers, as Eileen pointed out, to advocate for better healthcare. So that's a picture of one of our home care workers getting arrested in the halls of Congress while defending the ACA and Medicaid. But this model also has limits. It depends on state politics. It's vulnerable to attacks on public employee unions that we've seen in a lot of places because authorities are creations of state labor law. It also doesn't help on the agency side where we face similar challenges. So a couple of years ago, we set out to design a federal proposal that would deal with some of these issues. Next slide. So we first identified the dual crises of affordability and workforce, and I'm not even going to go into those because I think everyone understands them. Our solutions were financing. We need more funding. We deliberately, so I would say as a philosophical principle, we believe in long-term care financing reform broadly and creating a social insurance program. We decided not to do that. We decided to be incremental and build on Medicaid. We wanted to tie wage and training standards to the new funding, but we knew we can't just say to Medicaid, oh, tell states what to pay. We knew we needed to create some infrastructure to aggregate workers, so something like a public authority, and we knew we needed to increase the worker pipeline. So we know there's a large gray market that includes undocumented workers. So part of our plan was creating a pathway to citizenship for workers who had agreed to work as home care workers. So we pushed these ideas with every single Democratic presidential campaign. And then the pandemic hit and the 2020 election opened up a bunch of actual possibilities to propose something. Next slide. So I will just, I'll skip over this, but I'll just point out that both in Biden's initial Build Back Better plan, sorry, that's President Biden's initial Build Back Better plan and his American Jobs plan is the first time a politician or a candidate and a president has actually said the words care infrastructure. I think it's the first time. But there weren't a ton of details. And so we needed, and the we is SEIU and a broad coalition of disability and aging groups. we needed to actually put the details into the legislation. So next slide.
Oh.
So in the summer of 2021, Senator Casey and Rep. Dingell released the Better Care, Better Jobs Act, and that does have the nuts and bolts. And I want to just focus on the main elements. So the main element is a large infusion of spending, currently about 150 billion over 10 years. And so that does two things. It allows more people to get care, and it creates more home care jobs. We expect that a lot of these jobs will be IPs because the consumer-directed model is increasingly popular and in fact expanded during the pandemic. Importantly, the new money takes the shape of an FMAP increase. So that is the federal medical assistance percentage that determines how much money states get from the federal government for their Medicaid program. So kind of similar to the ACA, where states got extra federal funding if they expanded Medicaid, states would get extra funding if they did a couple of things. It's conditioned on them meeting two sets of requirements. So first, they have to actually expand the number of people getting services. But then, and this is kind of unique and new, they have to undertake specific activities to strengthen the workforce and the Hcbs infrastructure sort of generally. So they have to develop a public process for regularly updating payment rates to ensure that there's access to services. And the process has to include workers. They have to ensure that the higher payments go to the workers. So in the case of IPs, this process determines a rate and the IP gets it. In the case of agencies, the agency is the provider, they would get the rate, but they would have to show that they were passing it on to workers in the form of higher wages. And then the second thing they have to do is develop qualification standards and training opportunities for workers for all the reasons that Robert laid out. And we know, that this is going to help reduce turnover and improve the quality of care. So, and then very uniquely, the states would get another smaller FMAP increase if they created a version of a public authority, which would aggregate workers. It would recruit workers, it would register them, and it would connect them to consumers. And frankly, it's also the sort of mechanism that allows workers to come together in a union, which we think is another key element of ensuring and raising standards on an ongoing basis. So we think these provisions you're on, yeah. No, you're on the right side. So we think these provisions together could be transformative, adding dignity to these jobs and to the lives of people who need services. On a more mundane note, I would say that this provides a roadmap for both regulatory and future legislative action. And I say that because we don't know what's going to happen with Build Back Better. But this, if Build Back Better goes nowhere, which I don't want to think about, but if it does, we have this blueprint and it's exportable into a broader long-term financing sort of proposal. And there are a number of things that we think we can do administratively, which I'm happy to talk about in the discussion. Next slide. And so then just finally, I want to say, I just want to point out that we already have taken a small step towards this vision. So the American Rescue Plan that passed a year ago included a temporary 10% increase in FMAP. And states were not required to address workforce issues, but practically every state does have a workforce element in its state plan. And they're doing the actual things they would be required to do under the BBB. They're increasing rates, and with pass-through requirements, some states are actually have required the state to do a review of whether rates are adequate, and they're creating training programs. So as far as I'm concerned, this is a proof point both of the fact that this is sort of the right way to go. It's also because it's temporary and only for 1 year, also a proof point of the need to pass something soon that will continue this. Next slide, last slide. And so leave you with is from an art installation we did on the mall, emphasizing that care work is human infrastructure.
Great, thank you so much, Sarah. So our last speaker will be Veghte, who is the director of Washington Cares Fund.
Well, thank you so much for having such an interesting panel, and I'm happy to be here today to join you. My background is that I've worked in social insurance. I was at the National Academy of Social Insurance leading their policy work for several years. And I was at, after that, I was at Caring Across Generations, working with the National Domestic Workers Alliance, which is our partner organization, on designing care infrastructure proposals around, long-term care, paid leave, and child care. Universal family care encompasses all three. And I also earlier in my career was a professor of comparative social policy at the University of Bremen in Germany. So I studied the German system of long-term care, as well as some other European and Asian systems that exist. And so that's my background. I've been asked to speak today about the link between financing and job quality, and how publicly funded LTSS programs can generate the revenue needed to pay for quality jobs in this sector. I'll talk a little bit how we do this in Washington and how Germany has done it as well, and some challenges they face. I think the takeaway here, to get to the lead, is that social insurance programs can generate a lot of revenue, and it's really convenient to have a lot of revenue when you're trying to pay workers and have quality jobs. Revenue is a key component to it, and I'll talk a little bit about how that has come to be in Washington State and in other countries that have similar programs. So Washington State is similar to all other states in that we spend a significant state budget, probably more than most. We spend a little over 6% of our budget, our general fund budget, on long-term care, mainly through Medicaid, LTSS, long-term services and supports. And with the age wave coming, we expect the population 85 or older is going to double in the next 15 years in our state. And over the next 18 to 20 years, the population 65 and older is going to double. And so with the age wave coming, the long-term care costs associated with the age wave would have overwhelmed the Medicaid program if we didn't have WAC Cares in place. WAC Cares is a social insurance program that works like Medicare or Social Security, where everyone pays in, everyone benefits. It works like any social insurance program. Paid leave works similarly, and what that does is bring a new revenue source in. Every worker's paying in from their first job to their last job, and so we're getting a little bit ahead of the age wave, or bringing in revenue at the same time and a little bit prior to the peak of the age wave, to help fund long-term care for everyone in an intergenerational solidarity community. So two steps have made our program in Washington and similar programs in other countries able to generate revenue for care. And there are existing social insurance programs for long-term care in the Netherlands, Germany, Japan, South Korea, Taiwan, and Singapore has recently introduced something that I haven't looked carefully at yet, but seems to be similar. In order to enact these programs, as Eileen spoke to, the history of this, of how we think about care, I agree completely with her analysis, and it's so important to start there. If you start on the legislative side, it's hard to be successful unless you are moving society as a whole from sort of a paradigm, affecting a paradigm shift in society as a whole in a couple of ways. So the two ways that social insurance generates revenue are first of all, because it's a powerful organizing tool, and So it's based on medieval guilds from the 1300s, which throughout Central Europe, if you were a cabinet maker in Bruges, and there were 13 of you in the city, you all faced the same biological and economic risks, and you had a shared identity community and a shared interest in protecting yourself against those risks. As long as you had work, you could pay it, you could live okay. But if anyone got injured or sick or old, they could no longer provide for themselves or their families. And people started contributing to shared funds, solidarity funds, in these self-help organizations, in these worker organizations in the 1300s, in the guilds. That translated, that developed across the world. It came into the Caribbean. There are care workers in Harlem in the 1920s and 30s who had come from the Caribbean, who had similar arrangements. Workers across the United States in the 1600s, 1700s, 1800s had similar worker self-help organizations, always founded on a community of identity and interest. So you had German engineers had their own, Italian, and whatever profession it was often ethnically based. They were often, that was a problem with the American labor movement, is that it was so heterogeneous, both ethnic, it was balkanized by profession and by ethnicity and by race. All of those fissures in the American worker community, which limited our ability to mobilize collectively. All of those fissures existed, but the foundations of social insurance were in these solidarity communities based on a community of identity and interest. In the late 19th century in Germany and in the United States in the 1930s, the idea of a national federal government emerged, which took that model of solidarity and made it based on national solidarity rather than professional or ethnic solidarity. And so you get these national retirement and health insurance, social insurance programs emerging at that time as the idea of the nation emerged. And so that was a key move discursively. I think that a key takeaway here is that if you want to enact a social insurance program at the state or federal level in the United States that generates a lot of revenue to provide quality jobs in this area, the first step is persuading the public that there is a community of identity and interest that they need to be a part of, that it's not other people who need care, it's them themselves. It's not welfare, it's not social assistance, it's all of us. Every family faces this problem. To protect myself against this risk, I want to be part of a solidarity community that will protect me. I can do it better together than I can on my own. I can't possibly save enough to pay for the money that I would need to care for myself or a loved one when I'm 85, on top of having to save for retirement. And so persuading people that it's in their interest and they're doing it for themselves and not for other people, I think is sort of the secret sauce of how social insurance programs are able to get enacted and be popular and generate a lot of revenue. A second cognitive and discursive step is the one that Eileen spoke to, which is that the next step is to take the idea, even if people agree with the idea of a community of identity and interest, and they're willing to participate in a solidarity community, then you have to get them to see care as part of the public sphere, not part of the private sphere. So that's another big discursive shift. And that also, both of these take a lot of communications investments to change paradigms in the public understanding of this. So the term care infrastructure is really the key to that. That was a discursive move about 5 years ago that a lot of people worked on. We worked on it at Caring Across, and seeing that we suffer our American political culture, or liberal political culture, dating from John Locke and John Stuart Mill, is predicated on the idea that workers can satisfy all their welfare needs through wage labor as long as they work hard, right? And so, and that care work is done by women and women of color in the private sphere, and that reproduces so it's the social reproduction of labor for the workers who are participating in wage labor. And that is so deeply rooted in our political culture that it takes a lot of work to shake people up and make them understand, or help them understand, that that's no longer the case. Now, the sociological reality underneath that paradigm has shifted over the last 5 decades. There's virtually no stay-at-home family caregivers anymore. It takes all adults in a household to work in order to pay the bills. Gender roles have changed. The labor market has changed. And so that paradigm, it probably never really applied in the first place in reality, but certainly doesn't anymore. But people haven't made the cognitive leap on that. If you do focus groups or surveys, people tell us that the private sector can take care of this somehow, right? Or people can do it on their own. And so it just takes a lot of communications investment to lay the foundation for legislative change in this area. Even if there's a generous public program like ours, which generates a good amount of revenue. So in Washington State, we enacted in 2019 the WAC Cares Fund, which is a social insurance program for long-term care. Everyone pays in about a little over 0.5% of their wages to get a $36,500 a lifetime benefit that goes up with inflation over time. We pay out the benefits. So even with that revenue mechanism in place, that's only part of the puzzle. The other part of the puzzle are the things that Robert spoke to and Sarah spoke to. Strong collective bargaining agreements. So in our state, we have a very strong, SAU 775 has done a fantastic job of getting strong collective bargaining agreement with a good base wage, and then the opportunity for career advancement, the kind of things that Robert spoke to that are so important. It's also all programs like ours or the ones in other countries that try to address this challenge. They face the same trade-off between how many people are you going to cover, what are the amount of benefits per person that you're going to pay out, and how much you're going to pay the workers in the system. And that is kind of a triangle, and there are trade-offs in those decisions. And it's a political challenge because there's always going to be more beneficiaries than there are workers. And so, if you underpay your workers, you can pay out more generous benefits. And that's kind of the way care has always worked in this country and around the world, that you exploit the workers in order to provide cheap care to the beneficiaries. And so that requires, if you don't have a strong collective bargaining agreement in place, you don't have wage protections and other things that Robert and Sarah spoke to, then even having a generous social insurance program like we have wouldn't be sufficient. Germany is an example of this. So in Germany, they have a generous social insurance program, but they've struggled on the workforce side. They pay out a big portion of their benefits in cash benefits. So they give beneficiaries the choice between cash benefits or service benefits, or a combination of the two. When you pay out cash benefits, families have an incentive to get as much care as they can for, more bang for the buck. And the experience in Germany was that people would pay undocumented workers they would underpay their workers. There's a whole system that's emerged in Germany of workers coming in from Eastern Europe through agencies that bring them in to do 24-hour care for people at very low wages without any job protections. And the main union in Germany, Veghte, has not organized this workforce. And this goes back to all the challenges we've had in the United States with different workers from different ethnic and linguistic backgrounds. The unions have had trouble historically, for a lot of reasons, to organize people from different cultural backgrounds. And in Germany, that's been the same problem. They haven't organized those workers. There was a court case recently saying the Supreme Court ruled that was these were illegal arrangements because they were not protected by the labor protections that are supposed to apply. Very similar to what we've heard today about the history of job protections in this sector for American workers. So those are challenges they face. Germany is taking this on now with a program called the Concerted Action for Care, where they're trying to do a lot of the things that that Robert spoke to. They're having stronger base wages, opportunities for advancement with higher wages as you move through, stronger qualification systems for workers in this sector. Immigration, they're considering better immigration policy with the path to citizenship. So those are some of the policies that they've considered there. Another aspect of this, which the Germans are looking at, which is interesting, is trying to take some of the pressure off of the formal long-term care system by having, a surrogate workforce policy in long-term care is to have strong paid leave policy. So they're considering having like a program where you could get up to 2 years of paid leave to care for an older adult or anyone who needs long-term care, where you would get 2/3 of your wages replaced for up to 2 years to leave your job to take care of someone who needs long-term care. So that's I think another model people should be open to is how can we most of the care in the sector is done by family members, so having a strong paid leave system could be a way to allow loved ones to take care of their loved ones without losing their place in the career ladder. If you have job protections there, and without all the sacrifices that family caregivers make in terms of lifetime retirement savings and economic security and career advancement and so forth. I'll stop there and pass it back to you, Mieke, for questions.
Super. Thank you so much, Ben. Okay, so now we'd like to open it up to questions or comments, discussion. So, Suchi.
Okay, thank you very much. This is a very interesting session, really very timely.
Wait, 1 second. Hold on 1 second. So can you hear okay online? Maybe you move just a little closer to that microphone. That'd be okay. Here we go. Thank you.
I have two questions. One is I'd like to know more about a few things. Sarah, and others, Robert, and also, you mentioned about, the need for, collective bargaining. To have the workers' voice, right? That's very important in improving the quality of the working conditions as well as this. I just want to know how many are unionized or organized. You mentioned something about the National Domestic Workers Alliance. So I just want to know what numbers are we talking about, what proportion of domestic workers? And then among the caregivers, especially working in institutions or facilities, to what extent do they have access to collective bargaining? And then the other question I have has to do with, I think, the elephant in the room. We talk about the care industry. So I'd like to know a little bit more about, and there's obviously, several of the speakers today raised the issue of the role of public authority or government, right? Or having a social contract between government and society on this issue of care. So I just want to know, what is the proportion of the agencies that are nonprofit and those that are for-profit? Do we see, for example, like in the case of Canada, you have some multinational corporations as well as in Australia that operate? Because I think this is very important also when we talk about, the care infrastructure and how do we move forward. So I'd like to hear your thoughts on this.
Thank you. Okay, who'd like to go first?
I can start with Robert's help, and you can pitch in. So you're raising difficult questions because of the sort of, and I'll try to answer them, but it would probably take a really long time to answer them fully. And I would say the bottom line is we don't know as much as we should because of some of the lack of data collection, which frankly, as far as I'm concerned, is a result of, is a reflection of the marginalization of this workforce. Like, we don't collect data because we don't care about them, right? So so of the 4.6 million direct care workers, so as I said, a lot of those are home care workers. They're also workers who are working in other settings like supported employment, group homes for people with developmental disabilities. We know we have 600,000 IPs who are organized. We know that in the group homes in a lot of states, but not all states, those were formerly public employees. And so they continue to be represented in some cases by SEAU, by AFSCME, by other, if I had to make a guess, I'd say maybe that's at best another 500,000. That's probably optimistic. And then we at SEAU represent agency employees in New York, particularly, and scattered throughout, but agencies are hard to organize because they tend to be very small, kind of mom and pops shops. So, it's at best half the workforce, and probably less. And I would say, Washington is a proof point because there we do have a lot of density. So we represent the IPs, we represent a lot of the agencies. When the IPs set their wage level, it carries over to the agency, but Washington's a fairly unique situation. Do you have anything to add? It's just it's a great question, but a super hard one to answer.
No, I agree with that. And I think, going back to your point about data limitations, I mean, understanding what percentage of the workers are unionized, and understanding kind of the for-profit and kind of versus nonprofit proportion within the industry. There's probably better data on the second. At PHI, we study the workforce and less the industry. And so I'm sure there's data, and I could text one of my researchers. I was trying to find something online to share that stuff, but there is. I would say there are, taking it at a higher level, I think there's a few points I would make, which is that, when we have studied states that have really moved the needle on job quality and direct care, and kind of what were the factors that led to that, I mean, unions were a big part of that, right? And I think when you look at some of these model states like Washington State and California and New York, and even in so many other ways like Build Back Better at the federal level, it's hard to imagine that we would as a country have made as much progress on direct care job policy improvements without unions, and thus without collective bargaining, right? So I do think that theory and that premise is right. And yet union density is not strong in many states, right? And so it's, as we think about solutions for direct care, it becomes, how do we fashion kind of policy and industry solutions that for now that don't rely on union density or collective bargaining, because we still need those kind of ideas, right? On the piece around for-profit or nonprofit, I think there are a few areas that merit more research and more understanding. It is true that that there's probably something there. Are nonprofit maybe better with workers than for-profit? Is like, to what extent are they mission driven versus margin driven? Also, what percentage of the money is being eaten up unfairly by operating costs, or high staffing salaries, et cetera, versus going directly into compensation or other improvements? I think that should be better studied and maybe mandated, so that we better understand where that's going. But I do think, and what we've seen also is that in the last few years in particular, it was the smaller or nonprofit or for-profit, it was the smaller providers who were more vulnerable to Medicaid shifts. It was providers that were based in rural areas, or providers that were based in kind of underserved urban areas, working primarily with people of color and immigrants, that were most vulnerable in that closed shop. And it left many states, especially rural states like Maine, in a complete catastrophe. I mean, I was speaking yesterday with somebody in Maine, and they drive, I think, 2.5 hours for like a dentist, right? And home care providers, it's impossible to imagine a delivery system that would meet need based on that reality, and especially as shops close. So I do think that better understanding kind of the bottom line and the business imperatives, I think, of providers and the way it affects job quality is one piece, but also reimagining how we think about care delivery in a world where it's becoming less and less financially viable to stay afloat as providers. And I'll say one quick thing, which is that I was presenting in Colorado right before COVID started, and it was for a rural audience. It was rural lawmakers who were on the state. And one of the questions that came up from an advocate in the community was, how do you incentivize local officials in rural areas or providers to kind of emerge in rural areas if there's no money to be made, right? And someone said, well, even if there's not enough money to stay afloat, right? And so I think we need to ask ourselves harder questions about care delivery in the 21st century, in today's world and in the future, right? As we think about improving jobs and creating those kind of protections, right? Because it is a very different reality.
So we have some, our online panelists would also like to get involved. So Eileen, why don't you go first?
Right. You asked about the National Domestic Workers Alliance. Well, this reminds us that so much of our services are really in a version of the gig economy, that there's a huge informal sector that's very difficult to get at. In California, according to some older data, but it's most recent, there's 300,000 domestic workers who enter some 2 million California homes, and that's California alone. And who gets classified as what? This is a problem. It's been problems historically with jurisdiction when it came to unionization, but also in this field, when the Department of Labor first put up rules for overtime for domestic workers in 1975, it excluded home healthcare workers essentially. And with the change in the companionship rule that SEIU took the lead on that, and my co-author Jen Klein and I were an amicus on in the Harris, involved with that kind of work, that we find that the rule was changed that if you do less than 20% of your work as domestic work, then you can be a personal attendant or a care worker. But in many of these informal settings, domestic workers are doing care. They're either nannies or they're attendants. And so what the line is between the household work that is necessary to keep a person comfortable and domestic work, and who gets classified at what, and who can be in a union and who can't, and who gets paid for what, is increasingly difficult as there's this push towards even more informalization in the economy. And that's why the notion of just giving money to consumers can be difficult, because there is a race to how much can I get? And that's why the funding becomes a major question, as well as changing attitudes. Robert's narrative.
Thank you. Good. Ben, I'm going to call on you next. And also there are a couple of questions for you in the chat. So maybe when you're done responding to this, you could pick up those.
Happy to. Thank you. So I think the problem with the rural areas, I think, well, I'll get to that in a moment. First, I just wanted to agree on the importance of unions, and it's we're very lucky in Washington State that we have such a strong union density, but the SEIU has had such strong leadership here. But Medicaid, I think, is structurally always faced by the trade-off of, if wages go up, that means the state can provide less benefits to beneficiaries, right? There's always that ugly trade-off, and that's a challenge. And I think to make sure that those wages, the jobs remain quality jobs despite that, it takes strong unions fighting in the legislature to win that. Otherwise, it's a one-sided fight. Where social insurance, I think, offers a real opportunity is that two ways. One is that there are new programs, and so when you're designing a new program, you can get into the legislative process and get involved in the legislative process and try to include components to the legislation that addresses this issue. So that gives you a real opportunity to structure something in a new way at the moment of creation. Secondly, social insurance programs, we're trying to cover everyone in the state. So a big part of what my team is doing right now is trying to plan for a provider network that blankets the state, including rural areas. And I do think that if you build it, they will come. So if we have just like there's been we did a lot of research at the National Academy of Social Insurance showing that Social Security, well, and also at the another organization, Social Security Works, finding that Social Security is critical to the economic vitality of rural communities, because who stays in rural areas? Older adults, and those Social Security checks keep all the small businesses open in those communities. Those people use them to go to the local stores and so forth. And without Social Security, a lot of rural communities would suffer. It's true of Medicaid as well. But with a social insurance program for long-term care, where you have all of these older adults having $36,000 to spend on long-term care, that I think home care agencies will start to open up in those areas, and we're going to certainly actively cultivate that through our proactively trying to build out the provider network. But I think having that revenue there in these communities to pay for the care, to a large degree, a large amount of revenue in these communities should bring home care agencies there. The questions in the chat, what can be done administratively? Like I just said, I think I spoke to that. When you're designing a new program that gives you opportunities to structure it in a way that's good for workforce policy, I don't think it's very hard to do that within Medicaid because of the trade-offs without unions fighting for things. Anna asked in Germany, do workers on the 2 years of paid leave have any type of job protection? So that is a policy proposal. It's being studied now. It's not yet active policy, but in the proposal, yes, there would be job protection. They're modeling it on their paternity, maternity, paternal leave policy. So family leave. So Germany has paid leave for raising children as an existing system, but it doesn't apply to the elderly. It's being reformed right now in a variety of ways. But the new proposal would take what they do for paternity and maternity leave, parental leave, and do the same thing for long-term care. Nancy asks, isn't there concerted action for nurses as well? Well, that's just a translation issue. It's a konzentrierte Aktion Pflege, and Pflege means nurses, but it also means care. So it's the same word. So a concerted action for care exists in Germany. It encompasses nurses as well. Part of it is increased pay, increased training opportunities, and upward mobility opportunities, but also giving nurses more autonomy to make decisions around care without doctors being involved. So demedicalizing care is another part of it. Another thing I would just throw out there for people to look at is the Brzorg model in the Netherlands, which is a model of self-governed nurses associations of like 12 nurses in a locality who are given a pot of money from the long-term care social insurance program in the Netherlands, and then the nurses manage the care for their beneficiaries in a self-governed way. And that is a model which empowers workers there, and it provides holistic care to beneficiaries, and it's been pretty successful there. So,
thank you. Okay, I think we could take another question if there's another question in the room. Yes. Oh, so online they had a little trouble hearing Sergi, so please speak into the mic and speak up.
I'm Erika, and I recently got a PhD from the University of Brzorg, and I moved to Washington just to introduce myself for the people online that can't see me. Thank you so much for the panel. It was a very interesting discussion, and I have so many questions. So I will ask only two of the questions that I have. As we know, many domestic care workers are illegal migrants, and happens because their work is in the house. So it's more their work is invisible, let's say, to the public. And so I would like to ask how much unions are able to reach out to the illegal migrant workers, and what actions unions can take to protect and improve the conditions of these workers. And then my other question is related to the hiring process, because when I moved to the US, I tried to understand how I could hire a domestic worker, and I went online and spent several hours trying to understand what I have to do for legally hiring someone, and I couldn't understand it. So I asked people around me that were living in the US, and basically I couldn't find much help because so many people hire domestic workers without a contract, or and many times this happens because domestic workers again are often illegal migrants, and so it is not possible to legally hire them. And so finally, I was thinking that when the hiring process is more simple, it is more probable that the household will hire legally the domestic worker, and therefore they will receive more protection and more rights. Thank you.
Thank you, Erica. Okay,
I think I'm happy to address of those. So on the first, on the role of unions and undocumented workers, unions represent workers who sort of slightly differently than in most of Europe. By definition, our members are in an employment relation and in an official employment relationship. And to the extent that immigration law is enforced sort of at the employer level, most of our members are not going to be, in theory, none of them are going to be undocumented. I would say that as a union and beyond just the representation of our members, we have for a long time and continue to fight for immigration reform. And I mentioned in the course of the discussion that part of our original proposal, and frankly, this was due to our really good work with NDWA, involved a proposal to create a pathway to citizenship for undocumented workers who, as you said, are doing a lot of the work already. I would say the reason that's not in Build Back Better is because of the specific congressional rules that allow this legislation to get fast-tracked. But it is very definitely still part and parcel of our sort of larger plan, because there is no way to solve the sort of pipeline issue, the need for more workers without that. Mm-hmm. And then on your very good point on, I think the reason a lot of people are paying under the table is they don't want to deal with the hassle of hiring somebody legally. Because you gotta technically, pay Social Security taxes. I mean, there are a whole bunch of things you have to do. I would say there's some lessons from the IP model and from the authority model here. So states, when they have a consumer-directed model, will, and as I pointed out, the individual consumer is technically the employer, but they get a lot of support from the state. So the state will hire a fiscal intermediary who does all kind of the sort of back office-y, providing health insurance, well, not providing health insurance, but doing the sort of deducting the taxes, the employer sort of responsibilities that it's really a pain in the ass and really hard for individuals to do. So in a Medicaid context, I think it becomes easier to hire somebody legally. Again, that's a Medicaid context, though I don't know what the solution in the private marketplace is, except frankly, I would say to have authority-like structures which can sort of act as agencies that do that work. And frankly, also not only do that, but act as aggregators of workers for the provision of benefits like healthcare. Mm-hmm. And sorry, just one more note. I would note that the Washington, the social insurance, the program Ben's talking about, it was created in a way that you're not just giving people cash, you're and saying go forth and try to find a worker and try to do it legally. It is created in a way that you have to go through a structure to find the worker, and there have to be certain standards about the worker, about worker sort of supports. And the reason it was created that way is because SEIU helped write the legislation. Mm-hmm.
If I can just add, I agree with all of that. Just a few additional points. I think one of the reasons the gray market exists in long-term care is that people cannot afford what's available in the current system and often need to create their own arrangements. And it puts both the worker and the consumer at risk of exploitation. But it is indicative of a kind of an economic system that hasn't been designed well in long-term care. We've been studying immigrants in direct care for years. And one of the challenges is that we're not able to study and understand the gray market, where undocumented immigrants, we can imagine a large percentage work there, but also a lot of U.S. citizens work there. And it's a real data gap that prevents us from understanding who they are, the challenges they're facing, and so on. We're also not, and I think it's fair to say that long-term care would collapse without immigrants, that like the economy, like healthcare, they're so reliant on immigrants at all levels. And in fact, major advances in medicine and science have been tied to immigrants and so on. We've been advocating for a few solutions. I mean, certainly an earned pathway to citizenship, for all workers, but also for direct care in particular. We will also believe in kind of temporary visa programs that have strong workforce protections and that do offer an earned pathway to citizenship again. For the care sector, Canada has something in that regard, and we think that there's an opportunity for the US to design something that's worker friendly, that doesn't put the worker kind of at risk of exploitation by a consumer who necessarily does that. And the third is there are a number of organizations at the state level in various parts of the country and at the local level, immigrant rights organizations that support workers on how to navigate the immigration system. And some of them, like a group in New Mexico, have developed home care training programs for immigrants. And as part of the training and certification process, they help the immigrant also navigate the immigration system, which is complicated and hostile in many ways, right? And so there are ways in which states can step in and say, here are how we're supporting immigrants.
Thank you. Okay, we just have a couple minutes left, and there was one question online which now has
Yeah, I just answered. I typed an answer to it because I think Sarah answered the question about how do we organize family caregivers, and it's the model that she spoke to, what we do here in Washington, because in SAU, as she said, rightly said, helped enact that component of our program is having an aggregate, meta employer where the state functions as a fiscal agent, essentially providing the back office, the benefits and the wage. You have regulated wages and benefits, and that's handled through the state. We're currently transferring that to a nonprofit, that functionality, but it's still the same mechanism, which essentially organizes all the family caregivers into one employment arrangement where the state is the employer, and you can have regulation of the quality of the jobs.
I just want to end with the notion that the workers today on the ground are immigrant workers who are here in legal status, are counseling other immigrant workers. We see this particularly in LA with the Filipino Worker Center, and another one that's in Pomona, and on their rights, on giving them solidarity, giving them during the pandemic, people giving care packages, etc. And this is really important. And it's important that we see that national organizations, unions and Caring Across the Generations and the various coalitions are also very aware of this. And it's this synergy between the different stakeholders and sectors that really gives us hope.
Great. Thank you so much. Okay, thanks everyone for an excellent panel. So now I believe that we'll have a short coffee break, and then we'll have our closing plenary.
Great talking with all of you this morning.
Yes, thank you. Thank you.
Thanks, everybody.
Bye.
Bye-bye.